Assalamu alaikum wa rahmatullahi wa barakatuhu. Today we will be discussing a critical intersection, Ramadan fasting and cardiovascular diseases. Specifically, we will address the question of whether individuals with heart conditions can safely participate in this important spiritual practice. This is a complex topic requiring careful consideration, and I hope to provide you with a comprehensive overview of the current understanding. We will explore the delicate balance between these two, looking at the latest research and practical advice. Let's begin. This is the outline of our today's presentation. We are going to specifically focus on the risk stratification for fasting in patients with cardiovascular conditions, provide general recommendations based on the available evidence, and try to formulate a decision pathway for clinicians and patients to follow. The Muslim population of the world is currently estimated to be close to 2 billion, and the majority of them are going to fast during the month of Ramadan. Adult Muslims are obligated to fast during the month of Ramadan if it is safe to do so. Abstinence from food, drinks, intimate relations from sahur till iftar, and also, depending upon the geography and season, duration of fasting can be from 12 to 20 hours. However, there are certain exemptions to Ramadan fasting for those individuals whose health may come to significant harm from fasting. These are the patients with significant mental and/or physical health issues, and frail and elderly patients. Also, Muslims are permitted to break their fast if they become unwell, and they can make up their fast if and when they fully recover. If Muslims are in doubt about their obligations to fast with respect to their medical condition, they are encouraged to consult with their healthcare providers and their local Islamic scholar. As we already mentioned, the most important aspect of managing patients with cardiovascular diseases who are willing to fast during the month of the Ramadan is to risk stratify them, and this is the first step. However, unfortunately, there is no randomized control trials, guidelines, or expert statement on the management of patients with cardiovascular diseases who wish to undertake Ramadan fasting. We have extensively searched the available literature, and the consensus report and general advice in this presentation are adopted from this article. The link of this article, I am going to post this in the description of this video as well. So if you are interested in trying to further read about this topic, you can go through this article as well. Coming to managing patients with cardiovascular diseases during the month of Ramadan, the most important step is to risk stratify these patients. And these patients can either be low to moderate risk, and such patient may be able to fast, but they have to listen to medical advice. And these are the patients with stable hypertension, with stable angina, stable non-severe heart failure with left ventricular ejection fraction more than 35%, or patients with heart failure with preserved ejection fraction, patients with implantable loop recorders, with permanent pacemakers, either single or dual chamber, patients with mild or mild to moderate valvular diseases, with supraventricular tachycardias, atrial fibrillation, non-sustained ventricular tachycardias, and mild to moderate pulmonary hypertension. So this is a category of patients who are deemed low to moderate risk as per our current understanding. The next category are the patients who are deemed high risk, and they should not fast. These are the patients with poorly controlled hypertension as defined by your specialist, or patient who has suffered recent acute coronary syndrome, myocardial infarction within the previous 6 weeks, patients with hypertrophic obstructive cardiomyopathy, patients with severe valvular diseases, severe heart failure but without advanced features, patients with poorly controlled arrhythmias, and also patients with high risk of fatal arrhythmias, for example, inherited arrhythmogenic syndromes, arrhythmogenic cardiomyopathy, in patients who have implantable cardioverter defibrillators or cardiac resynchronization therapy. And the last category are the patients who are deemed very high risk, and these must not fast. These are patients with advanced heart failure and patients with severe pulmonary hypertension. This is just a checklist for you so that you have an initial idea of how to categorize these patients. Which patients are deemed high risk, which are very high risk, which are low to moderate risk. Always keep in mind that fasting is associated with dehydration. Dehydration may lead to electrolyte abnormalities which could be life-threatening in at-risk groups. And these at-risk groups are those with unstable arrhythmias, with inherited arrhythmia syndromes, for example long QT or Brugada syndrome, or patients who are taking medications such as class 1C antiarrhythmics, digoxin and renin-angiotensin-aldosterone antagonists. Fasting can affect your cardiovascular health in many ways. Always remember that fasting can precipitate dehydration because there is less fluid intake, and the patient might be taking diuretics which can cause excessive loss of water from your body. All these factors lead to dehydration and electrolyte abnormalities which could be life-threatening in at-risk groups. For example, patients with unstable arrhythmias, patients with inherited arrhythmia syndromes, for example long QT or Brugada syndrome, patients taking medications that are pro-arrhythmics, for example class 1 antiarrhythmics, digoxin and renin-angiotensin-aldosterone antagonists. Additionally, fasting may also provoke non-adherence to usual treatment schedule. To facilitate fasting, the patient usually split their doses or skip their doses, or for certain class of medications, for example, which are being taken at twice daily doses in the usual days, now they have to change their dosage either into a once daily regime, or they are going to take the medications in twice daily regimes, but the duration is changed and it's not that standard twice daily routine now. This can be very dangerous in patients who are taking, particularly those who have undergone recent PCI and are on dual antiplatelet therapy. And if they make unnecessary changes into their dosing schedules, this can result in fatal consequences of stent thrombosis or bleeding. Same goes true for patients who are taking anticoagulant medications in twice daily dosages. So non-adherence to the usual treatment schedules may result in dramatic consequences for the patient. So these two factors, dehydration, electrolyte abnormalities, non-adherence to usual treatment schedules, may precipitate hypotension certain medications, and this can result in syncope, particularly in elderly patients. So always keep these 3 points in mind: the risk of dehydration and electrolyte imbalance, medication schedule, and the risk of hypotension and syncope. So now let's briefly go through the current literature on fasting and cardiovascular conditions. First, let's talk about hypertension. So from this article by Aslan et al., diuretic therapy in patients with hypertension appears to be safe. Ramadan fasting appears to significantly decrease systolic and diastolic blood pressures in individuals using diuretics, which was well tolerated without complications. From Aldib et al., what they found was that there was improved blood pressure control in patients with hypertension, irrespective of renal function, and improved arterial compliance in those without CKD in patients undertaking Ramadan fasting. Temizan et al. In their study found that there was no significant differences in the incidence of acute coronary syndrome in Ramadan when compared with the preceding or following month. So the incidence of new acute coronary syndrome cases are same to those of non-Ramadan months. So you are going to encounter these patients during the month of Ramadan during your practice. So always keep this point in mind, that the incidence of acute coronary syndrome is not significantly affected by Ramadan. When we talk about patients with percutaneous coronary intervention, Amin and Alar found that patients who undertook Ramadan fasting within 3 months of percutaneous coronary intervention had a higher incidence of significant cardiac events than those who did not undertake Ramadan fasting. From Khafaji et al. And Musavi et al., who did their observational study on patients with chronic coronary syndrome, Ramadan fasting was not associated with increased cardiac or morbidity, with 29% of patients reporting improved cardiac symptoms. So this is very significant. Almost every third patient had improved symptoms during the month of Ramadan. SGLT2 inhibitors, very important class of medications. They have been approved across the guidelines as a class 1 recommendation for patients with full spectrum of heart failure, whether they are suffering from heart failure with reduced ejection fraction, mildly reduced ejection fraction, or preserved ejection fraction. So these drugs are very important. However, their use does require certain precautions. These drugs should be initiated at low dose in the evening and at least 1 month before Ramadan. Fluid intake should be increased during the non-fasting hours. So any patients who are taking SGLT2 inhibitors, they should increase their fluid intake during their non-fasting hours. Hypoglycemia should be avoided by reviewing any concomitant medications for type 2 diabetes mellitus, although theoretically the risk of hypoglycemia is significantly less with these medications, but concomitant medications such as patients who might be taking sulfonylureas or might just be at risk of developing hypoglycemia. So their medications should be thoroughly checked and any offending medications should be adjusted. SGLT2 inhibitors should be avoided in elderly, in patients with CKD, or those receiving loop diuretics. Arrhythmia is a very common occurrence, and after ischemic heart disease and heart failure, it is the third most common presentation for cardiovascular disease. The European Society of Cardiology 2020 Sports Cardiology advises that patients with long QT syndrome should carefully avoid dehydration. So this is one of the caveats from the guidelines on sports cardiology published by the European Society of Cardiology in 2020. As per these guidelines, patients with long QT syndromes are susceptible to the harmful effects of dehydration. Fasting can also lead to dehydration. In general, we can say that fasting under certain circumstances may not be beneficial for patients who are suffering from long QT syndromes. Self-made changes made to their anticoagulation regime with potentially fatal outcomes, bleeding or strokes. Apart from dehydration, another important thing to remember about arrhythmias, in particularly patients who are suffering from atrial fibrillation and who are taking anticoagulants. We already mentioned that there are going to be non-adherence to the medication regimes, and there are going to be changes in the intervals that the medicines are taken. Patient can also make changes on their own to their anticoagulation regimes. For example, a patient taking twice daily doses of anticoagulation, for example apexaban or dabigatran. The altered dosing schedules may pose these patients to the adverse effects of anticoagulation. The effect of anticoagulation may be enhanced, resulting in bleeding complications. On the other hand, the effects of anticoagulation may be blunted, resulting in thrombotic complications, and the risk of thrombotic complications while a patient on anticoagulation is increased if they get dehydrated. So always keep these factors in mind while you addressing and educating a patient suffering from arrhythmias on these medications, and they are here with you for Ramadan counseling. They should avoid dehydration in patients with hypertrophic obstructive cardiomyopathy, in patients with adult congenital heart disease, particularly the cyanotic variants, and patients who are suffering from orthostatic intolerance syndromes. This is from the current literature. What the literature is saying about the various conditions some important drugs, and some important precautions. So from all this data, one can easily say dehydration is the main point of concern for most of the conditions, for the medications. It can by itself result in adverse events. It can enhance the adverse effect of drugs, and it can have synergistic along with certain vasodilators like the renin-angiotensin-aldosterone system antagonists with SGLT2 inhibitors. And this is a very important aspect, that the patient should be clearly educated upon this particular point. How to avoid dehydration, how to adjust the medications, and things like this. So we are going to discuss this thing more in the coming slides. So now we can formulate certain general recommendations based on the available evidence to these patients. How you are going to approach an individual patient. So this is the pathway, and this is the consensus stepwise approach for the pre and post Ramadan checklist for reviewing patients with cardiovascular conditions. The first step is to establish patient's background, previous Ramadan fasting experience, symptom status, smoking status, cardiac and other medical history, medications, and compliance. Past history of the patient is very important. Every bit of information that is important, whether that was the patient's previous Ramadan experience, his or her current symptom status, whether or not the patient is smoking, and what kind of medications these patients are taking, and in the form of cardiac medications, patients taking medications for their comorbid conditions, and are they compliant with their medications or not. Once you have done this, then the next step is to review recent investigations. These investigations include urea and electrolytes, ECG, imaging, for example, if required, a fresh echocardiogram, plus minus intracardiac device check ppm programming, and things like that. Then you have to risk stratify the patient, communicate with the patient, and if required, manage the patient. Risk stratify the patient, as we already mentioned, the patient can either be classified as low to moderate risk patient, high risk, and very high risk patients. Patients with diabetes and CKD can be referred to Ramadan specific guidance, and patients should be communicated regarding the risks, and they should be counseled regarding the adverse effects, and they should be advised how to manage and how to communicate with your caregiver in case any help is required, and risk management including medication review. So this is the third step. You have to establish the patient's background, then review recent investigations, risk stratify the patient, and then general Ramadan advice is given to the patient. That should include advice on healthy diet and fluid intake. Smoking breaks fasting, so this is an opportunity for smoking cessation. Terminate fasting if feeling unwell, and intramuscular injections and sublingual meds do not break Ramadan fasting. So this is important. And towards the end of Ramadan, after Ramadan, then you have to perform a post-Ramadan review. Explore experience of Ramadan fasting to guide future fasting and symptom status change. Whether Ramadan fasting has helped the patient's symptoms to become less or become more. And this particular Ramadan experience can be used as a reference point for future Ramadan planning. This is important. Once the patient has been assessed, the next question is, does the patient intend to fast in Ramadan? If that's not the case, continue current management. If the patient is willing to fast during Ramadan, the first step is risk stratify the patient, and we have already mentioned that. For patients who are low to moderate risk, the recommendation is that they may be able to fast. Is the patient taking cardiac medications? If that's the case, medication optimization should be done, and compliance should be endorsed and proper monitoring should be done in those patients. Then risk communication should be made with these patients. Inform the patient of the risk status, that is, they are low and moderate risk, and document patient's risk status and patient's decision to fast. And then you have to risk manage these patients. Counsel patient about risk of dehydration, fluid overload, electrolyte abnormalities, and consider alterations to medications as appropriate and feasible. Advise about sick day rules and to terminate fast if becomes unwell. Consider trial fast, for example 1 month before Ramadan. Patient fasting with safety monitoring. So this is the final recommendation for patients who are low to moderate risk. Those patients who are high risk patients, the general recommendation is that they should not fast. Okay? However, they can still choose to fast, explore alternatives if safe. For example, non-consecutive fasts, alternate day fast, fasting on weekends, or fasting with breaks. Fast shorter days in the winters. Ritual compensation, for example, providing food for a certain number of individuals in need. Still the patient declines or is unsuitable for alternatives, then the risk should be communicated with those patients. Check if the patient is aware of the health consequences of Ramadan fasting and that they are fasting against medical advice. Document patient's risk status, patient's decision to fast, and recommendation for them not to fast in clinical notes. Okay? So if generally they should not fast, but if they are still choosing to fast, first give them alternative options. If they are still not pursuing the alternative options or they are not feasible, then risk communication should be done with these patients. The patient's mental status should be checked, whether they are aware of the health consequences of Ramadan fasting and that they are fasting against medical advice. Document patient's risk status, patient's decision to fast, and recommendations for them not to fast. All these things should be documented in your clinical notes. And finally, risk management. Advise patients to speak to a local scholar about their decision. Counsel patients about risk of dehydration, fluid overload, electrolyte abnormalities, and nutritional requirements. Consider alterations to medications as appropriate and feasible. Advise about sick day rules and to terminate fast if becomes unwell. Consider trial fasting, for example 1 month before Ramadan. This should now be clear and much more easy for most of us to explicitly tell our patients their risk category, risk associated with fasting. So now coming to the important segment of medications, and we know that the patients who are suffering from various cardiac conditions will be taking a bunch of medications, not only for their specific cardiac conditions but also for their comorbid conditions, for example for diabetes, for hypertension, thrombotic complications, and so on and so forth. So let's discuss the important ones. So first let's talk about the AC inhibitors, the aldosterone receptor blockers, the angiotensin receptor neprilysin inhibitors, Arrhythmias, and ARBs. These drugs are used in patients who are hypertensive or patients who have heart failure. These medications may be associated with certain risks during the month of Ramadan while the patient is fasting. They may worsen fasting associated hypertension, which may result in dizziness or loss of consciousness, may compound fasting associated dehydration resulting in an acute kidney injury and or life-threatening electrolyte abnormalities, for example hyperkalemia. Medication non-compliance may result in uncontrolled hypertension or decompensated heart failure. So both extremes of the spectrum are possible in these patients. On one side, patients are at risk of the adverse effects of these medications. On the other hand, because of the non-compliance or alteration in the dosage intervals may result in uncontrolled hypertension and in some cases may precipitate decompensation of heart failure. Patients will be taking antiplatelet medications, for example, aspirin, clopidogrel, prasugrel, ticagrelor, if they are suffering from coronary artery disease, from myocardial infarction, or patients who have undergone recent PCI. The risk in fasting with these medications are many. For example, non-compliance can increase the risk of acute stent thrombosis, myocardial infarction, and death if antiplatelets are not taken regularly. Myocardial infarction and death if antiplatelets are not taken regularly, particularly in patients with recent coronary stent implantation within the previous 6 months. Remember that ticagrelor is taken twice daily and has a half-life of 7 hours. Patient may also be taking antiarrhythmic drugs, for example, amiodarone, flecainide, sotalol. These are for atrial tachyarrhythmias and for ventricular tachyarrhythmias. Some of these medications may worsen fasting-associated hypotension, which may result in dizziness or loss of consciousness. Fasting-associated dehydration may result in significant electrolyte abnormalities that may increase the risk of antiarrhythmic drug toxicity. Beta blockers, for example, bisoprolol, is taken for patients who are suffering from coronary artery disease, from heart failure, from arrhythmias, and from hypertension. They may worsen fasting-associated hypotension, which may result in dizziness or loss of consciousness. Medication non-compliance may result in worsening angina, decompensated heart failure, and more frequent arrhythmias. Calcium channel blockers, such as the amlodipine and diltiazem, are used for arrhythmias, for coronary artery disease, for hypertension, and just like the other drugs, they may worsen hypotension, and they also may worsen angina. Medication non-compliance may result in worsening of angina, more frequent arrhythmias, and uncontrolled hypertension. Continuing on, so this is a long list, and every class of medication is associated with those potential side effects. For example, patient taking digoxin. Digoxin toxicity may occur in potential cases of fasting-related acute kidney injury. DOACs, for example, apixaban, rivaroxaban, and edoxaban. These are used in patients with atrial flutter, atrial fibrillation, deep vein thrombosis, and pulmonary embolism. 2 times per day DOACs. The half-life of apixaban is 12 hours. If taken early morning, for example 3, and then again at, for example, 8 o'clock, there may be a period in between where the patient is not adequately anticoagulated. Medication non-compliance may result in stroke or death. Okay, so some other drugs, for example, immunosuppressants such as tacrolimus, if a patient has heart transplants, may compound fasting-associated dehydration and result in acute kidney injury and or life-threatening electrolyte abnormalities, for example, hyperkalemia. Medication non-compliance may result in organ rejection and death. Tacrolimus is taken twice daily, and therefore care must be taken to avoid long periods in between. Loop diuretics such as furosemide, bumetanide, and thiazide, for example, hydrochlorothiazide, these are used for heart failure and hypertension. Apart from their hypotension and dehydration, they may worsen fasting-associated dehydration, and acute kidney injury may occur in these patients. Also, there can be life-threatening electrolyte abnormalities, for example, hyperkalemia. Medication non-compliance may result in uncontrolled hypertension, decompensated heart failure. Mineralocorticoid receptor antagonists, for example, spironolactone, may worsen fasting-associated hypertension, similar to the other diuretics, as we already mentioned. So they also pose additional risks to these patients. And sildenafil and other phosphodiesterase 5 inhibitors for pulmonary hypertension, they may result in diarrhea, worsening fasting-associated hypotension, and things like that. So every medication, the patient who are taking them, they carries their innate adverse effects, and fasting-associated adverse effects should be kept in mind. The patient should be counseled regarding each and every medication, their potential side effects. And apart from the possible side effects of the drugs, non-compliance may result in the worsening of the underlying cardiac condition. In summary, each patient is assessed individually, and the three important components to remember are risk assessment, whether the patient is low to moderate risk, is high risk, or very high risk. Use of the decision pathway, as we already mentioned. The decision pathway will identify patients who are at low to moderate risk, high risk, and very high risk, how the low to moderate risk patients can fast safely, and additional instructions for patients with high and very high risk for fasting, that how risk communication is done to them. They are counseled regarding the potential hazards that fasting can have on their health, and if despite counseling and reassurance they are still willing to fast, how can we manage those patients, how can we manage their medications, what advice should be done to those patients in case of emergency. And step 3 is medications review, as we already mentioned. This is important. The crux of this whole presentation is that you have to assess each patient with these three individual components, risk stratify them, use the decision pathway, and finally review their medications. So now, can we recommend patients who are having hypertension, their blood pressure, kidney function, and medications, particularly antihypertensives that have a diuretic component such as aldosterone antagonists or thiazide-like diuretics, should be reviewed to reduce the risk of hypotension and or worsening kidney function. These patients should be advised to do home blood pressure monitoring, to monitor their blood pressure, and to correlate symptoms of hypotension with blood pressure. Patients with well-controlled blood pressure are deemed low to moderate risk for fasting. Patients with chronic coronary syndromes. Low to moderate risk patients can safely fast, and patients should be compliant with medications. Patients with recent acute coronary syndrome within the previous 6 weeks or up to 3 months should not fast. These are high-risk patients. These also include patients who had recent cardiac surgery. As far as patients with heart failure are concerned, patients with heart failure who are low to moderate risk, they should fast safely. High and very high risk patients may not fast. Stable patients with heart failure with preserved ejection fraction should fast safely. Patients with intracardiac devices, pacemakers, whether single or dual chamber, these patients are deemed low to moderate risk and they should fast safely. However, patients who have ICDs and CRT, these patients are deemed high or very high risk and they should not fast, because you know that ICD and CRT are implanted in patients who are already suffering from either advanced heart failure or from potential life-threatening arrhythmias. Any disease where there may be significant risk of dehydration or hypotension should be classed as at least high risk, such as patients with severe aortic stenosis, hypertrophic obstructive cardiomyopathy with LVOT or mid-cavity obstruction, severe and uncontrolled arrhythmias. And finally, remember that fasting is not suitable for patients with severe pulmonary arterial hypertension, with cyanotic adult congenital heart diseases, and post-cardiac transplantation. Alright, so the take-home message for today's presentation is that the literature on Ramadan fasting in patients with cardiovascular disease is limited. Encouraging medication compliance and monitoring to enable patients where safe to do so to fulfill their religious obligations while minimizing the potential for harm. Other comorbid conditions should be kept in mind while assessing the patients. And finally, further studies are needed to explore gaps in knowledge around fasting and to help refine current recommendation. Thank you very much.